Brilliant. Well, we are over now to Helinor McAleese. The introductory slide is there in front of you. She's the TP based at Barts Trust, but she's at Newham. And if we take ourselves back to that period of time in late March, when we were all listening to what was happening in Italy and how a health service in a major economy can be completely consumed within a few weeks, we had the development of the Nightingale hospitals, and it is perhaps a testament again to how well we did that they were not as needed as they were, but they had to be available in case the tsunami completely destroyed the health service, as it may have done for a few weeks in March. So we are delighted to hear from you, Heli, about everything you learnt about that work. Over to you.
Hi, can you hear me?
Beautifully.
Yes, wonderful. So yes, hi, my name is Heli. I'm a transfusion practitioner for Barts Health. So just briefly going to, I haven't quite finished my first page yet, walk through my experience of the provision of blood transfusion service. For 5 weeks of my life, I was consumed by Nightingale. I ate, lived, breathed Nightingale, while still having to maintain my own hospital site. Next slide. As I'm sure you are all aware, the NHS Nightingale Hospital London, based at the Excel Conference Centre, was specifically constructed to support all NHS London hospitals in the event of a surge of COVID-19. Designed to provide care for patients who had already been intubated and ventilated and required further intensive care treatment for COVID-19. The Nightingale was designed. The Nightingale was intended as a safety net for London NHS should demand exceed capacity. At full capacity, the hospital would have the largest critical hospital in the world, with 4,000 beds. Opened on the 3rd of April, impressively, only 10 days after the idea was conceived, with a capacity of 500 intensive care beds, fully equipped with ventilators and oxygen. Having treated only 57 patients, the Nightingale has now been placed in hibernation, ready to serve once more if so required. Next page. So on the 30th of March, the Board of Barts Health NHS Trust, on request from NHS London, agreed to host the Nightingale Hospital, taking on formal legal responsibility for the operation and governance. With the requirement of blood testing and blood provision, the blood science team were asked to aid in the implementation of a transfusion service. As you can see the layout of the Excel Centre there, I'm not sure if you guys are familiar with the location, but it's a rather large site, and I've marked the spot X as the location for our pathology reception. Next slide. So pathology reception was created. As you can see, this consisted of temporary walls set up in a corridor with a PIN code access, a swift implementation of lab cold blood bridge having a 68 unit capacity. Preparations were put in place to establish the Royal London's capacity to take on the potential increased workload, where a decision was made that an additional IH500 analyzer would be required to meet both existing services and Nightingale needs. Next slide. Nightingale Hospital, having a very unique setup of a dirty and clinical area, clinical area and a clean area, the non-clinical area. Full darning and docking procedures were to be followed. Therefore, process mapping was required to establish workflow from the clinical area to pathology reception to the Royal London and vice versa. This highlighted many issues. Once staffed were actually donned and entered into the clinical area, they remained within that area and do not come out for the duration of their shift of 12 hours. Therefore, how were samples to be retrieved? How were blood components to be requested? and how were blood components to be collected while adhering to cold chain compliance? Whose responsibility was it for the selection and issue of blood components? These are all key questions that we needed to ask and devise a system for. SOPs and documents were quickly drawn up. These procedures could not be simply taken from established protocols from Barts, but had to be unique to the requirements of the Nightingale. A manual system was devised utilising a component request form that also incorporated a collection log and traceability element. It was decided also for the safety of the Nightingale patient and risk assessed that all requests were to be made directly with the Royal London lab, stating a turnaround time of 3 hours minimum and providing Group O for all patients initially. On site, there were always going to be the availability of emergency red cells with an established code red system consisting of 2 red blood cells and 2 FFP. Due to the short turnaround time and the constant evolving process, adapting and aligning existing processes and procedures to support the Nightingale, keeping both Nightingale and Royal London team informed, often became extremely challenging. The Nightingale reception was run by a team of 9 medical students and supported by Barts MLAs working 24/7. At any one point, there would always be 1 MLA and 1 medical student on site. However, having no lab experience or background, all individuals had to be trained for the maintenance of the blood fridge, blood stock management, as well as the process for blood requesting and collection. Our blood stock fridge at Nightingale at any one point had a stock of 6 O pos red cells, 6 O neg, and 4 FFP. As often is the case, blood transfusion, although vitally important, was not included in the initial induction of clinical staff. This caused a real issue on the alignment of timely training to ensure safe provision and administration of blood components. Compliance to Statamen at first was extremely poor, and in the month of April, we also experienced a rejection rate of 45.2% of all glucose screen samples. So, pose the question, how was the information to be communicated to the clinical team? How do we ensure that safe practices were implemented? We devised training and information documents that were created and provided for staff. Training of porters for the collection of blood components was planned, and we performed debriefing sessions at handover at 8 a.m. and 8 p.m. Naturally, having 5 sites of Barts Trust, there were only 3 TPs at the time, one of them working remotely. So we did find that working across all sites, maintaining our own hospitals as well as the requirements of Nightingale was overwhelming. So we did outsource and recruit some of our local London TPs who were accredited, came in, and we devised a rota where we, at any one point, there was always at least one member of the TP team who were there as a reference, a training resource for the pathology reception. And we are forever thankful for their coming to our hour of need. And next slide. So in total, 48 units of red cells were transfused to our Nightingale patients, and 2 units of platelets and 2 units of HAS. From my experience, there is a need for commonality in processes with neighbouring trusts to facilitate responses to pandemic major incidences. A training passport with key components agreed across multiple trusts, making sharing resources easier in unprecedented times would be of great value. I myself have taken my learning and applied it to my own trust, ensuring that as part of my bank staff induction, good transfusion practice as relative to my hospital was included. So a huge number of volunteers and staff are involved in the setup and running of Nightingale. It has been an incredibly humbling experience to work alongside so many people from multiple disciplines across the NHS who have come together to work for this very important cause. With special acknowledgement of course, our own Barts team, especially Pascal Winter, who worked tirelessly throughout the whole procedure of the Nightingale, our transfusion team and consultants, and Kath and Laura, who were always there for support. Nightingale was a fantastic location to work despite the current climate, and I feel morale, as ever, was highlighted with free food.